Hello, everyone. Good morning, good afternoon, probably good evening as well, all over the world. My name is Getnet from the International Institute for Primary Healthcare. I'm a senior research advisor. So today we are going to have a very interesting webinar topic, creating resilient PHC systems, including particularly the lessons learned. And we have really distinguished scholars talking about this. So this is one of our monthly webinar. Just to briefly introduce the International Institute for Primary Healthcare, usually this is a collaboration between Johns Hopkins University and the International Institute for Primary Healthcare. So the International Institute for Primary Healthcare was established by the Ministry of Health in 2016. So it's very young, as you can see, with a vision of becoming a center of excellence in primary healthcare. In fact, initially it was really to countries to learn about its health extension program or primary healthcare program. So this was jointly between the Ministry of Health and Johns Hopkins University. Now, really, we have evolved, and you can find most of the things what we are doing in our website. I'm sure you have seen it. So we have at least 4 programs, major programs. The National Primary Healthcare Program, which is supporting the national program. We have a global primary healthcare support program, supporting the national primary healthcare program, including our health extension program. And there is also a knowledge generation and management where we have really a center, a computer center where we collect all primary healthcare related research all over the world and really access it to other people. We have also an advocacy and partnership unit. So we are working in these 4 broad areas, and just recently you have seen that we had also a conference on a global conference on primary health care. So today, as we have really, as I said, 3 distinguished panelists, which will be introduced by the moderator. I'll be introducing the moderator from the World Health Organization, from Ghana Health Services, Ghana, and also from the Ministry of Health, Ethiopia. Now, I'm honored to introduce the moderator, who is Dr. Tolbert from the Johns Hopkins University School of Public Health Department of International Health. Really has a very fat CV, very rich experience. I cannot go into detail, but I would highlight the most important really ones. Dr. Tolbert is a researcher. He is also an interagency personnel of the US National Institute of Health. He is an internationally recognized legal scholar. He specializes in health policies, strategies, planning, and also, which is very important for us also today, is in disease control and prevention, particularly in public health emergencies and preparedness. And then he was also appointed in various positions, particularly in Liberia, cabinet positions by President Ellen Johnson Sirleaf. He was advisor to the Ebola crisis several times, including in Africa. Still, he's an advisor appointed by the president. Again, he received several awards. Maybe to mention a few of them, the Liberia's highest honor and other awards. He is an author of a book called Collapse and Resiliency, the inside of story of Liberia's unprecedented Ebola response. He's also an author, has authored and co-authored more than 107 peer-reviewed publications in the last how many years? So this is briefly introducing Dr. Tolbert. He can really, if I have missed, he can add to that. But now I give really the floor to him. So over to you, Dr. Tolbert.
Professor, thank you very much. That was a great introduction, Professor Makiti. Fellow colleagues, participants, good evening, good morning, good afternoon. It is indeed a privilege for myself and the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins University family to moderate this session on behalf of the International Institute for Primary Health Care of Ethiopia that we as a university have been partnering with since its inception in 2016 to support low middle income countries and support the rich healthcare worker extension program in the great country of Ethiopia. And so today we are pleased to be here for this PHC primary healthcare webinar, strengthening primary healthcare system in low and middle income countries. I know you all agree with me that pandemic and epidemics have taught us a lot of lessons that a weak primary healthcare system or a weak healthcare system in totality cannot withstand the shock of epidemics and pandemics. And this is why it is critical for us as a global health community, especially those of us from low middle income countries, to pay critical attention to primary health care as a core, as a backbone, as the fulcrum of healthcare system. So today we are excited that you have joined us. We will spend some exciting time together discussing these issues and putting meaning to what is primary healthcare and resiliency in pandemic response, pandemic preparedness, epidemic preparedness and response. After I myself have led one of the worst Ebola outbreak in history in Liberia as the incident manager of the Ebola response at the time, the 2014-2016 Ebola response. We saw how it ravaged West Africa, and the entire world were brought to its need. Leadership crumbles around the world to deal with that crisis, and we are grateful that at the end of it all, the predictions that thousands and thousands of people, 200,000 people were going to die and millions were going to be affected. Because of the interventions that we put in place very quickly, we were able to halt the situation. And then after, we saw the COVID-19 pandemic that ravaged the entire world, from the global south to the global north, and everyone were brought to their need for this. So we will see these crises over and over as we come back and combat some of the worst pathogens in the world. And this is where the environment, the One Health approach of human environment, the interface come together so that we get prepared well for these diseases. Having said these few comments, we have three incredible speakers for today to provide us an insight for what's happening in the global experience. We get experience it from Ghana and experience it for Ethiopia. Our first speaker will be Dr. Xavier Bernd, who formerly from the WHO. And Dr. Bernd is an executive head of the Global Pandemic Monitoring Board, Secretariat, which is an independent monitoring and accountability body to ensure preparedness for global health crises She was previously director of the Epidemic and Pandemic Preparedness and Prevention Department at the World Health Organization headquarters in Geneva, Switzerland. For more than 20 years, our distinguished speaker has been leading the development and the implementation of global strategies to prevent and control epidemics and pandemics such as COVID-19, Mpox, formerly monkeypox, Zika, Nipah, influenza, Ebola, cholera, plague, and the rest of others, emerging pathogens. And she has played an incredible role, including incidental and delivery events management. She has been directing the development of many global mechanisms and sustainable framework to facilitate multilateral, multi-sector, and multi-partnership coordination for pandemic and epidemics. Distinguished ladies and gentlemen, our speaker.
Many thanks, Dr. Tolbert. It's really a great pleasure for me to be with you today and with the other speakers. And I see that there are many participants with us as well, so it's a great event. I will share my screen with some slides. Is it okay? Can you see my slide?
Yes, your slides are clear.
Okay, okay. So, yes, as you said, I am now the leading head of the Global Preparedness Monitoring Board Secretariat, but I have been for the past 2 decades the director at WHO of the Epidemic and Pandemic Department. So you see on these slides all the epidemic or major epidemics and pandemic we had since the beginning of the century, such as SARS, avian flu, H1N1 pandemic flu, H7N9, MERS, Zika, Ebola, plague, Mpox, and finally COVID-19. And I've been part of all these response as a WHO civil servant, and worked with many of these countries. And maybe we have met Dr. Tolbert in Liberia in 2019.
Yes,
because
I realized that.
I was there as well. But just this slide is more to show you 2 things. First, that we have more and more of those crises because the world, we are more connected, people are moving a lot. So when people move, viruses are moving as well. And so we will have more of those shocks in the future. But at the same time, what you see on the bottom of this slide is that the global public health community has developed mechanism also to work together and tackle those emerging threats. So we have the International Health Regulation in 2005, but we also had the PIP framework after the H1N1 influenza pandemic, the Pandemic Influenza Preparedness Framework. And now our member states of WHO are negotiating the Pandemic Accord. So the negotiations are still ongoing and really they are not finished, but we hope to have some initial results at the next WHA, World Health Assembly, in May 2024. And negotiations are ongoing to develop this global accord to see how all the countries in the world can collaborate and how they can also better coordinate during epidemics, large epidemics or pandemics events. Because there is this global negotiation, so I think this is an important part, especially for pandemics, but nevertheless, we all know that epidemics start and end in communities. So it's not enough to have this global level, we also need to have a local level of response and preparedness. And it's especially very important for emerging disease because you see that diseases, especially emerging disease, it's not like earthquake or floods or, you know, it starts slowly usually. It starts with 1 or 2 cases when it's an introduction or emergence of a disease. Then you have a localized transmission. so few people are infected, and then it amplifies, and you have sustained human-to-human transmission. And after some time, if you have a vaccine that boosts immunity, or if people become naturally immune, we see usually a reduced transmission of the disease, because our bodies are ready to fight the pathogens. But it's very important to look at this dynamic, because we have an opportunity to prevent pandemics and large epidemics when we are still at the stage of localized transmission, because this is where the event is manageable and you can still stop transmission. When it's amplified, it's much more complex, and often we have just to try to mitigate the impact, because we cannot really stop the virus anymore. So this is why primary healthcare is so important for pandemics. And I've put here on this slide few arguments. First, because it allows a community-centered response. It reduces the spread of the disease and the mortality. It allows for the adaptation of public health and social measures. But if we want all of this to work well, we need to protect the health workforce. So let me go into details on those various elements. First, having primary healthcare is really important, because it allows to have this community-centered response. First, when you have a localized health worker or community health workers, they can better understand the local mode of transmission of the disease, and therefore be in a good place to stop the spread of the disease at source and contain the outbreak. And I would like to give the example of plague. For instance, plague is transmitted by a bacteria hosted by rodents. So if you understand very well the interface between human and rodents, you can really stop the spillover from animal to human much more effectively when you are really on site, and you can really tackle this transmission from animal to human. It also allows for better surveillance and response, and for example, discard what is endemic disease from the new emerging disease, because local people know better what is usually circulating, and so it's much better for responding and treating patients. And finally, it's also the best way to have an effective risk communication and community engagement and empowerment when you already have this primary health care. It also helps to reduce the spread of the disease and the mortality. First, reducing the spread because you can quickly manage patients, and especially when those patients are really contagious, by providing, for example, an Ebola treatment center at community level helps a lot to stop the spread in the community. But also it allows to protect the families by doing contact tracing or administrating prophylactic therapeutics. Again, this is what we do when we have an outbreak of plague, and it works very well. And then you can also implement what we call the test and treat approach. And this, I would like to give the example, for example, in Japan, because primary healthcare is not only for low and middle income countries, it's for all countries in the world. But in Japan, for example, during the influenza pandemic in 2009, they had this approach where they test for flu and they administrate immediately antivirals. And they were the only country in the world with no death in pregnant women in 2009, 2010. So it works, but it has to be implemented in the right way. And then primary health care also helps to adapt the public health measure to the local context. For example, for contact tracing, when population are really scared about international responders. I mean, local responders can have a much better relationship with them and have more compliance to the measure. It helps for also the communication and how we can better understand the concern and the question of the community. And also it helps for community empowerment because a lot of disease are really entrenched in communities because it's the way we live. the way we have contact between each other that allow for the spread of the disease. And I have put a picture of MERS and the relationship between people and camels in certain part of the world, because camels are really valued. So it's very important to adapt the measure to the local culture, to the local practices, so that they are better implemented and more effective. And one example during Ebola, and Dr. Tolbert can certainly comment about it, but for instance, is the implementation of safe and dignified burials with community workers that were trained so that it can reduce secret burials and the amplification of the disease and the spread within the community, but also in other communities that were not initially affected by the disease. But all this will work if we are able to protect the health workforce, because health workers are at the front line. These are really dangerous pathogens, very contagious pathogens. And when you are dealing with patients that are highly contagious, there is a high risk also for health workers to be contaminated. So they need protective equipment, they need training. And they deserve support during crisis, because the toll on the healthcare worker is enormous. And during COVID, we have seen so many burnouts among the healthcare worker population that it's also very important that health authorities take into account that these are only human, and humans deserve protection. And also, healthcare facilities can become hub of transmission for certain disease. So it's very important to have adequate infection prevention and control measures at healthcare facility level, so that we can be efficient in reducing the spread of disease. So just an example of Ebola in 2014, many healthcare workers died during this outbreak, and it has an impact, of course, on the response, because then you have less people to attend patients and take care of the communities, but also in the long term, it really undermines the capacity of health system to provide services. Especially when the density of physicians or nurses is very low. If you lose one physician, then 100,000 of people are without access to care given by doctors, for instance. And again, this issue is not only the protection of health workforce is not only in low and middle income countries, because I put an image of a nurse in Spain during COVID-19. And at the beginning of the pandemic, even in highly resourced countries, there was issue to access masks, access PPE in many healthcare facilities and hospitals. So if we want an efficient and resilient PHC during crisis, it's important also to adapt a little bit the primary healthcare services to the crisis and the epidemic, which means that we need to bring additional services and medical countermeasures at community level. For instance, tests, antivirals if they are available, and we do this, for example, for epidemics of avian flu in Asia. So we need additional services than the regular primary healthcare services. We need also healthcare facility to have a capacity to scale up, but this should be coupled as well with a safe referral system for severe patients, so that the primary level is not overwhelmed with the too many patients. But we need also to prepare this primary healthcare system to play additional roles, probably during pandemics. First role is really, they could be the glue that brings the community together and that enhance this solidarity at community level. And also PHC could be really an enabler for the trust and social cohesion during pandemic. And we have seen that during COVID-19 pandemic, trust was an essential commodity to make sure that the response is efficient and really mitigates the impact of the pandemic events. So all of this is needed, is essential, but has to be prepared for, because it doesn't happen necessarily naturally at the beginning of the crisis. So we need to work now to prepare a better and safer future. Thank you very much.
Thank you, Jack. Thank you for the great presentation, Dr. Sylvia. Great presentation. You reminded us again about having a connected world and people working together to fight diseases. You reminded us about the importance of IHR, the International Health Regulation of 2005. You reminded us about epidemics starting and end in the communities, and so communities must be prepared. You reminded us again and again about the protection of healthcare workers, having infection prevention and control, community resilience. You reminded us about risk communication, even during non-pharmaceutical measures, and mitigating community impacts have been very, very much critical, like contact tracing, that we don't have these vaccines and other countermeasures. We should make sure that the community is resilient. You talk about the safe and dignified barriers and medical countermeasures when they are available being deployed at the community, and making sure that we deliver efficient and resilient primary healthcare services. So thank you very much. It brings us down to our next speaker. Very, very insightful. We have gotten a global perspective of this. This next level is to know now country specific on what is happening in our beloved West African country, Ghana. Dr. Andrews will take us through. Dr. Andrew Ayam is the Deputy Director, Policy and Acting Deputy Director, Information Monitoring and Evaluation at the Ghana Health Services. He is a public health specialist whose job entails ensuring the development of global health security strategy, policies, and plans to contribute to the development of national health policies. He is presently part of the team leading the implementation of the network of practice strategy in the Ghana Universal Health Coverage Roadmap. He is also a fellow of the Ghana College of Physicians and Surgeons and a training coordinator that facilitates public health in Accra, Ghana, and facilitates training of policies. He's a clinician that worked at district level and coordinated HIV/AIDS prevention program in 5 West African countries, including Ghana. And what I loved about Dr. Andrews is that he's a sports enthusiast. He's passionate about football that took him to many, many, many countries. So, ladies and gentlemen, they welcome our next presenter, Dr. Andrews Ayam. Thank you, sir.
Thank you. So, like was said, all the lessons that was said by the previous speaker were learned by Ghana in terms of what the community concept is. So even though since Alma Ata, Ghana has emphasized that primary healthcare policy is the way to go. And we've done that through a lot of policies. And one of the things was the community-based health planning and systems concept, which we did. And since 2000, we have been working on it for these 2 decades. And then, of course, the National Health Insurance, so that with the UHC, the financial aspect can also be dealt with. And then we also introduced a demand aspect in a scorecard, where we call the community scorecard in 2018, where the communities meet to assess our activities. And then using 9 quality indicators, give us a score. And the score is simple: red, gold, green. So they usually, if we do well, they give us red. If we do well, they give us green. If we are moderate, they give us yellow. And if we are not doing too well, they give us red. And we are using that to also get information from the community in a perspective, whilst we also have the DHIMS2 data system, which also gives our side of the data. So we are triangulating the community data with our own data to see how we are working well. And of course, the vital signs profile was also done. So generally, the community work has gone on for a long time in Ghana. And we are believing that with the UAC, all people living in Ghana will have timely access to high quality health services, irrespective of their ability to pay at the point of use. And so payment mechanisms for the services we give are all being looked at. And in the recent past, when we looked at our preventive services, we realized that about 40% of it is not being funded by the National Health Insurance, and we are looking at financing mechanism. Of course, the donors were supporting us in it, but with the way the donor funding is going, we are beginning to look at other innovative ways of looking at the community in practical terms. So we had a lot of other problems that, aside the pandemics, we wanted to deal with. Of course, the early detection of outbreaks was key, but we wanted to strengthen the primary healthcare system also to improve demand. And of course, in terms of early infant diagnosis and all other things, TB detection, we really wanted to strengthen the community level to deal with all that. And our fight against malaria, we have said that we want to eliminate it using the community approach. And non-communicable diseases are also a big issue, and the need for screening and referrals and management at the community level has become our issue. So when all these things became very strong, then we looked at our district hospitals to understand how we rope them, because the highest point in Ghana for the primary healthcare is the district hospital, where the referrals end. But they were being overloaded because we realized that the middle level, which is the health centers, were not strong enough. So every issue went. And of course, during the COVID, the experience showed us that almost every person who needed some small oxygen or something small, we still needed to move to the district level, and we were not close to them in terms of quick interventions, and we had to create a lot of community structures. So we decided that now we are going to do a lot more permanent, strong primary healthcare community structure by strengthening the middle level, so that a lot more activities can be done in the community, and then the few ones can come to the district hospital, so that we can even improve the district hospitals' quality of services by not overloading it with so many clients, and also reduce the cost to patients traveling so far from their communities to get health. And then we looked at a lot of the problems that were at that level: poor administrative structures, case management capabilities, low service availability, poor equipment issues. So we've looked at all this, and we've come out with a strong concept to look at the issues and the systems. And we also looked at the system and saw that they were in silos, and we were not supporting them enough. And also, sometimes there were very unstructured systems in the community that we at the top didn't really understand. And our referral systems too were ineffective because they were not very attractive to the community. So the community were exposed to higher level technology and therefore wanted to reach further than close to them. And so all these issues were issues that were in the community, for which when a pandemic comes, the response is based on what they know about us in the community. And if the community is weak, then they struggle with us. So when the COVID issues came, we looked at the issues and the monitoring of it and the surveillance systems, and all these issues came up, and we looked at the regional variations and all that to understand, and we superimposed it on our health system and saw that no, we had a lot of weaknesses in the health system. Even though we still use the community system to monitor, and to date, for instance, there's only one active case in Greater Accra that, as at this December 2023, we've been able to pick, and we think fine. As the community gets more sensitive, our surveillance systems is fine. But we realized that in the vaccination campaign, we saw that, for instance, 43% of the total population has been vaccinated by half of this year. But what we realized was that the community's etiology of disease, what they understand about disease, was different from what the health systems understood. So sometimes when you say the etiology of COVID is a germ, they think it's spiritual, they think it's whatever, and therefore we need to still be in the community a little longer for them to accept our way of thinking about how to manage outbreaks and manage diseases. So generally, the policies that we did, the Ghana's Roadmap 2020, we did that. Then also the National Health Policy, we also have done that so that it encompasses everybody. And of course, this in 2019, the Strategic Implementation Plan for Primary Healthcare is launched, and we are, because of the COVID interference, now with the recovery, we are trying to see how well we can implement all these policies. So we said that the solution to the problem was to build networks among facilities in the sub-districts and to upgrade health centers into model health centers to lead this network, so that at the sub-district level, there's enough services for the people to respect the health system so that in outbreaks, they can always relate to the health systems better. So a network of practice in Ghana is a group of public and private health service delivery sites deliberately interconnected through administrative and clinical management models so that those will now deliver surveillance, deliver detection, deliver responses close to the people. And we've designed it in such a way that at the sub-district level, a health center will become a hub to the spokes of facilities there, and they will relate to the district health administration and the district hospitals so that we find ways of quickly linking them in that network and strengthening that network through different these configurations. And we are saying that when the hub, which is the health center, is strongly connected to the other systems, there will be seamless service, and the network will catch some clients who fall in between the cracks, especially when they are referred from one point to another point. And then we maximize the use of the resources, support they will get more support because now they are a network and the peers and hub will support them. And then we will kind of manage it like a whole of government, whole of society approach. So these are issues that now we've told all our regulatory agencies and all our support that this is how Ghana is organizing its health systems, so that the over-the-counter drug person can link to the health center and they can all work together. And the ambulance service can also link to the hub. The hub works with all the spokes and it gets better. So we are believing that with this policy, and of course, we've got support from the World Bank. Our government had to take some loan so that we can use it to equip some of the places and start lifting some of them into model health centers so that the community demand generation concepts will be higher, and therefore then other issues of surveillance, of disease detection will all come up very strongly. And we believe that when they are very interconnected, we pool the resources together, which are scarce at that level, we'll get robust health systems, and we would deal with the preventive, promotive issues and curative and even the rehabilitative because of the strokes and all that are occurring in the community. We are going to deal with that at the community level. So basically, in conclusion, we are saying that the networks of practice in Ghana will result in a resilient primary healthcare system. And the teamwork between the public and private partnerships at the lower level are going to help us improve our primary healthcare system to achieve the universal health coverage. And then we believe that with that system embedded in the community, we're going to get early detection and response to all our outbreaks and create a very resilient health system. Thank you very much. Over.
Wow. Thank you, Dr. Andrews, for very, very enriched presentation. We are doing great with time. Our audience, there is Q&A for you we'd love 30 minutes of Q&A. So just sit there, take your notes. Dr. Andrews have reminded us about Ghana's preparedness since the Ama-Ata conference on primary healthcare. Ghana has been emphasizing primary healthcare. And he also narrowed down with universal health coverage, including a health insurance scheme that put in place cards for accountability and delivering services. Spoke about data-driven solution, including universal access to, clinical primary health care. He talked about innovative financings that is not only donor dependent, so they are putting in place on innovations. And critically, in as much as the world is overburdened about, pandemics and epidemics and outbreaks, Dr. Andrews spoke about looking at and keeping an eye on endemic diseases like malaria, how Ghana wants to eliminate malaria, looking at HIV and AIDS, TB, and strengthening other healthcare system issues and non-communicable diseases. He stressed that very well, that weak healthcare system cannot support primary healthcare and epidemic preparedness. So they are bringing together hospitals, district level, county level, national level. And he spoke about community-sensitive surveillance. That's community-based event surveillance. And climaxing that, he talked about the solution of breaking the silos so that the network of practice people work together in delivering services for the population, because our role is population health. So thank you very much. Insightful presentation, nice presentation, Dr. Andrews. It brings me to our next presenter, Dr. Maritu Masibu, who is a public health specialist and senior advisor to the Minister of Health of Ethiopia, over 2 decades of distinguished experience in public health and health economics. He has expertise in shaping national and global response to health emergencies and pandemic preparedness, demonstrated exceptional leadership and national task force coordination during the COVID-19 pandemic, and currently leading Ethiopia's delegation at the World Health Organization in Geneva for pandemic call and the international health regulation amendments that we have all been talking about. So Dag, welcome, our next presenter.
Thank you. Thank you so much for your fond introduction. I'm very grateful. Thank you everyone for having me today. I'm very proud to speak about lessons of recent COVID pandemic in Ethiopia, and also give you some highlights of how we think to move from the acute management of COVID on health surveillance, epidemic preparedness, country capacity, which is focused on the lessons we had with COVID. I think Ethiopia is one of the known big country with 126 million population and the center for Africa and the home for all of the human in trying to lead the country and the global south on epidemic responses and the pandemics. So our thinking going forward will focus on primarily on what we have as a country already and possessed for the last 20 years. That is primary healthcare. So the focus of any pandemic preparedness, epidemic preparedness in Ethiopia, we believe in the world should be also on the focused on the creating resilient primary healthcare system, which is a very important topic that we are discussing today. So pandemic preparedness is very much important on if it's built from what we had in public health emergency management. In the progress, as you know, we have the oldest public health emergency management institute, which is Ethiopian Public Health Institute in Africa. So we started from 1998 on integrated disease surveillance and the response. Then we were pushing it as much as we can. Then we came up with comprehensive public health emergency management concept, which is, I think, unique and the first in Africa at that time. It's mainly focused on risk-focused surveillance than IDSR, which is disease-focused. Then we prepare from preparation to recovery. So we see the emergency cycles in between. Then a dedicated structure from national to the world level, which the primary healthcare is based. Now we are started to implement comprehensive public health emergency management, which includes all disaster, all hazard model together with multiple surveillance systems which focus on human, animal, environment, and related contribution for disease outbreaks. When I come to COVID response, the National Emergency Operating Center was activated before the first case detected in Ethiopia. As you see, it is in January. Then the first case reported in Ethiopia by March 11. Then I mean March 13. So even before the WHO declared as a pandemic, Ethiopia was activated with its emergency operating system. That's why I'm started with the fake the National Public Health Emergency Operating Center, which is very much important, already institutionalized in place to support the COVID response. Then also we moved to the highest level with national emergency declared by the highest level of the government. What we had as a lesson from this pandemic is like I'll mention some points that is very important for the audience. I feel in most of the global south and also for the global north. So global interconnectedness is well witnessed at that era. So the supplies, knowledge, scientific guidance we usually get, the people we usually get, the transport of samples we do for other outbreaks were all suspended at the same time. So we are very much reliant on our own. So it is so we focused on our community. So most of the response is led by the people in health system and out of the health system with community engagement. Another lesson very important was multi-sectoral collaboration. So for any pandemic, any epidemic, any outbreak, health sector will not be suffice for the response. So we collaborated with Interreligious Council, with Ministry of Education to focus on the student population, then security agencies, policies, which is very important, especially in the start. Ministry of Transport, which was very important for public health measures, private sector engagement, which was really valuable at the start. Then investment in public health preparedness, including gifting facilities, preparedness capacities, laboratories, institutions, academias, universities for better management of isolation and the quarantine function at that time. So we pushed for resiliency as we started with local manufacturing of mainly with public health measures like masks and the coveralls in our garment industries. Then we grown up as much as we can to have self-sufficient as we go in the pandemic. The other very important thing is the health extension workers. As it's well known, Ethiopia has a very nice, formidable fighters in the community level, health extension workers. So we have more than 40,000 health extension workers who actually engage by door-to-door information session, community engagement. So they knocked 50 million households in a 10-day time. So that was the greatest achievement we had at the peak of the pandemic to give information and to also sustain our primary health care, which were already started suffering, and to deliver some of the very important medicines and the health interventions for the community. So we try to work with professional associations. We try to leverage technologies with telecoms, with information networks, with already started Ethiopian community health information system at the household level. Then if these are the major lessons really we want to keep and we want to use for other outbreaks as we go forward. On the pandemic preparedness, the rapid response is very important. Continuity of the care, which is most important. You know, you cannot skew to the pandemic, to the emergency. So the primary health care should be kept as it is, as much as we can to mitigate the problem, because you cannot you can prevent from COVID, but you can lose people with malaria, with other outbreaks, because it is ongoing forever for us. So it's very important to balance that. Bridging the gap between specialized care and the primary care is very important to really decentralize as much as we can to the community level, the specialized care. Championing on the preventive care is very important. The communities, the health workers, the Warada, the Kabale levels, they are the ones who took the initiative for preventive care as we enrolled in the pandemic response. Building trust is a very important thing. So our Minister, Excellency Dr. Lia, including other distinguished professionals, we usually go to the media, to the social media, to give really actual message for the community. This is a very, very important thing to make the community to adhere with preventive facilities. So country capacity to prepare for future is also strengthened as we work with National Action Plan for Health Security. We have five-year health security agenda, which will expire this year, and we are having the new one in coming. So we did our joint external evaluation just a month in 2023. So we will build up from that, and we will go to strong national One Health platform, which was already established from the COVID and the previous outbreaks. So we'll work on that. That's a very important lesson we had to work on One Health platform that includes animal health, as our distinguished panelist earlier said. Every major outbreaks are start from zoonotic origin. So establishing a strong national regional emergency operating center is very important. Now we are moving from regional emergency operating center to the sub-regional emergency operating center in the decentralized fashion. Our experience from different outbreaks, which is based on health extension workers at the community level and recognizing interconnectedness of the world and the globe and the other sectors, which is very important for emergency response. So you cannot manage emergency without water, without engaging other sectors, energy, everything. And the language is very important. As you know, Ethiopia is multi-ethnic, multi-linguistic country. So we want to promote every actions to the community on their language of understanding. That's important thing. Another thing is like limited resources. It is always common to have the limited resources, but having the previous experience to use some innovative ideas, including mobile clinics, especially for nomadic society, for societies with internally displaced due to conflict and the drought. It is very important to have that mobile clinic to reach to the community. And also energy is very important because most of our diagnostic therapeutic capacities are in line with the energy necessity. So using solar power health centers is very important. So we are doubling down our efforts on solarization of the rural health facilities as we go. Local production of medical supplies is a very important thing to build a resilient primary health care we envision. Then technology and the real-time health data is important. I think we have a good lessons globally from some of the countries who were really prepared because of their previous exposure of MERS and other viruses. So they were very much prepared on technologically and also with response capability. So we learned that and we are working on digitization of our services. The recommendation for possible for other public health, primary healthcare systems in Africa or beyond, I think they need to focus first in the governance. Without governance, nothing will happen. So governance will yield financing, resource mobilization, resiliency, everything. So we need to engage the politicians. We need to engage the local governance mechanisms, starting from the community governance structure. Then strengthening our infrastructure is very important. I think we used mostly our infrastructure, which we built for previous pandemics like HIV, like malaria, TB. So those facilities are really used for COVID responses. So that's a very important. And the resource planning is the most important lesson we want to pass today. Then building a resilient workforce, which includes surge capacity. Like so, as a lesson we took, we worked with Africa CDC and WHO to have the national surge team. We trained 200 people for 1 month, which are multi-sectoral, from defense, from agriculture, from disaster management, the commission, everywhere. So we train them, we equip them, and then we will deploy them to Ethiopia. Then we will deploy them to anywhere in the world as we go forward. That is one of the areas we need to work in the collaboration forward, especially in the primary healthcare setup. Promoting domestic capacity for medical technology is very important. That's why we are trying to have a lot of therapeutics and including vaccines and diagnostic capacities in country to self-sustain for future pandemic preparedness. Collaborative disease surveillance is very important. We are trying to pilot most of the primary countries in WHO to really work on the collaborative surveillance with talked earlier. Enhancing digital health integration is important with existing system, which was a district health information system for us. Then community engagement and education, as I said, and the diversifying and strengthening supply chains is very, very important. So the pandemics can kill and other diseases also can kill. So we need to mind that the balance in era of the outbreaks. One important example I want to mention for you is Woreda-based risk profiling, which we started before COVID, and we did already more than 194 Warada through EPHI to profile each Warada by risk character. If you see this diagram, so it's shown us in the figure where the most of the outbreaks are happening, and we will focus our endeavors, our efforts on those Waradas as we go forward. Finally, the priorities for us is like event-based surveillance, discovery of unknown zoonotic viral threats with collaborative surveillance, with pathogen surveillance, including sequencing, lab-based surveillance, networks of programs. We never sequenced anything except the research purposes. But now we have a good capability to sequence and to report openly to WHO networks of laboratories. We prioritize research and equitable access to medical countermeasures and essential supplies going forward in Ethiopia and in Africa level. So communication is important, and the decentralized capabilities, which I talked about, is that we have a new initiative, which is focusing on at the facility, FAME at the facility, at the primary health level, regional EOCs, sub-regional EOCs, labs, and including involvement of academia and the national capacity expertise is one of the major things I want to mention. Thank you so much for having me, and thank you for giving me a chance.
Thank you, Doc. Thank you, Doc, for great presentation and what you've impacted so far is so enriching, concerning especially that primary healthcare systems, and there should be resiliency even after an epidemic or crisis. That you can speed up recovery and prevention and care for community level, especially community healthcare workers. You spoke briefly about, the importance of country capacity and delivering services and public health emergency. And what was intriguing so far was that the fact that before even the public health emergency of international concern was declared by the WHO, the Ethiopian government was proactively moving on setting up emergency operation centers and quickly responding to the COVID-19 through your leadership and other leaderships in the Ministry of Health. You re-emphasize the earlier point that Dr. Sylvia and Dr. Andrews made about the world being interconnected, the interconnectedness of outbreaks happening in one location of the world could impact other areas, and not only the health sector, but even at the economy, water system, education, sanitation, and all of those things could be impacted by epidemic. You re-emphasize the One Health approach in Ethiopia, that interagency collaboration, and then also community engagement, community-based practitioners working together, and then leveraging ICT as part of the strength that you mentioned. And then you make key recommendation about there is no substitute for political leadership, for political governance. There should be strong political governance that look at, all of the building blocks of a healthcare system that improves primary healthcare. I think our presenters, the presentations were mutually reinforcing. And so it brings us now to the point where it is now your turn, our dynamic participants, for you to ask your questions to. Please direct it to the specific presenter and the question you want them to answer to enlighten us and throw more light on what you have heard earlier. Thank you very much. Any questions or concern? Like, for example, we have a question for Andrews. What are the attitudes used for community scorecard in Ghana is one question. Another question is, could we say that Ethiopia has created resilient primary healthcare as part of its preparation to the next pandemic? If yes, share us. I hope Ghana accreditation practice is better. So who is the lead and how is the process and relationship with National Health Insurance Scheme? Those for now are the questions. So Dr. Andrews, you want to go first, followed by our other colleague.
Okay, thank you for the question. Already in the community, we have community health management committees, which are made up of community members. And they meet every quarter to do discussions on how the health system is interacting with the community systems. And they do other things in kind of linking us up to community issues, volunteers, and all that. So now they have this scorecard tool where now they call some of their members, about 15 members in the community. And when they meet in the quarter, they evaluate what the services have done. They go and inspect the facilities in their communities. And some of the indicators are, if, for instance, they are getting respectful care, or there's no drug available, or there's infrastructure is so bad, or there's something, all those quality indicators are the community health volunteers and health workers visiting their homes. Are they satisfied with the way they are visiting their homes? So those things, they mark as red, gold, green, whatever, and it's keyed into the electronic system. So at every level of our health system, we can pick it, and I can pick it in my office and drill specifically to the particular community and see that maybe respectful care is very low. So if, for instance, respectful care is low, but I noticed that on the supply side, my antenatal attendance is low there, or there's another factor that is low there, I can triangulate it and say that because we are not giving respectful care to the people, they are not coming to antenatal, and we can talk to the regional director who will work it out with the district directors, and it should go down. So it's the community health management committees who organize this particular meeting, and then it's done. Then when it comes to accreditation by the National Health Insurance, yes, we are continuing to work with the National Health Insurance, and they give accreditation to individual facilities. We are now working with them to see how they can do their actuarial studies and see how they can group accredit. For now, they are giving individuals. So what we are doing with them is that we are improving the efficiency so that the claims management, because if they are in a network, they will get better help, because sometimes only one facility has an accounting officer. And then because they are in a network, then they get more help, and then we get less rejection with the National Health Insurance. But we are still working with the National Health Insurance to change some of their policies to suit the network model, even though the previous policy was a single facility model. Thank you very much. Over.
Thank you. Great answers and great questions as well. Can we go to Dr. Masebo? Do you have some insight on the questions? And there is another one that said, could we say the new COVID variant is a critical public health problem in Ethiopia and in Africa? Thanks.
Thank you. Thank you so much. It's a very nice question. I'm trying to answer it in the chat also. So I cannot really boldly say in the first question that Ethiopia built resilient primary healthcare system or a system. No, like I think there is no country in the world that who can say that they have purely resilient health systems, because the resilient health systems are usually tested by shocks. Ethiopia really sustained many shocks, like we had past COVID, we had a conflict, we had droughts, and we had even flooding. Like we had flooding in the drought at the same day in Ethiopia, in part of Ethiopia. So our health system is really tested in the last 3-4 years because of different emergencies and the outbreak. So, but we cannot say like we really had that resilient system. We are working to make those resilient systems, especially focused on primary healthcare systems. We had universal health coverage, like if you know, this year the parliament passed a law which gives obligates the community to have health insurance, to have financing, domestic financing for the health systems, which part of it will go to the health emergencies. And also we are working on the workforce development. I think our universities are graduating many people, but there are big financing problems. So most of our emergency financing, including the primary health care, is financed by donors. We need to shift in the local capacity, but there is a competing priorities. So the government physical space is very low. Equipment is not that great. There are still people who can support the government system, the health system, who are not recruiting, mainly because of the financing issues. So there are lots of things we can work for the future, and we need to prioritize as we go forward, because the problem is a lot, and it's a resource constant country, you know. So even though we have the big plans at hand, it's very difficult to implement it without adequate financing we had. So this is the main things on the resiliency of the public health system. Another question on COVID variant, I think, as you all heard from WHO and different medias, we are monitoring the new variant. New COVID variant is a problem for the world, not only for Ethiopia. We have a surveillance system intact. We have central surveillance system. Our emergency operating system is still working. We didn't dismantle the emergency operating system. We integrated with COVID and other public health emergencies together. So we are in the watch mode to really learn more about this variant. But as you know, Ethiopia, relatively, we had a good coverage for vaccination in targeted population. There is also significant community immunity evidenced by different studies because of the infection. And we have a younger population relatively, on the attribution of many things which we pass the primary infection. But still, no country in the world is immune. We are really vulnerable as long as there is a vulnerable population we have. And we are looking, and the ministry is still active. We are coordinating national task forces still. So COVID is in our view, that we cannot leave it, and they will let the community know when we have adequate information about the new variant, which is just in the discussion. Thank you. I think these are the main questions for my side.
Yes, thank you. Thank you, Dak. I totally agree with you. No country is immune. Myself being a member of the panel of experts of the Global Health Security Index that assesses, 195 countries' preparedness. The conclusion of that, the second report of the index, is that no country is really prepared, whether it's high income or medium, low income country. So we all have to do everything possible to build resilient community healthcare systems. So Dr. Xavier, there is this questions from one of our participants, especially with your previous knowledge with the director of epidemic preparedness at WHO, and now as executive head of the Global Preparedness Monitoring Board, dealing with countries. And our country's colleagues can also share Ghana and Ethiopia experience on this one. Our participants want to know, how can we get governments and donors to invest more in primary health care and One Health? Health is wealth, essential for all country development. We saw the global disruption of trade, travel, supply chains, business due to COVID-19. Investing in frontline vaccinators, nurses, midwives, healthcare workers, and all frontline healthcare protects health. How will you react today, Madam?
Okay, thanks. It's a very important question, and also a challenging one, because we see that although these topics, at least primary healthcare and One Health are extremely important, it's very hard to get sustained financing. There have been some financing during COVID, for instance, during a crisis. There is more money coming in, but what we need is really a sustained financing, because a lot of things are systems, and systems cannot be built only for emergencies. You need to maintain them and strengthen them also during peacetime. So I think here there are two issues. One issue is that first, how to have a financing system for those topics that is resilient and sustainable. And I think the member states have done some progress. You know, recently a pandemic fund has been created under the auspices of the World Bank and WHO, trying to streamline money for preparedness activities. So these are the kind of initiatives that may help a bit to have a sustained financing, especially for a system like PHC that are really critical also during emergencies. So hopefully in the near future, there will be a little bit more support for this, but the gap still remain at, I think, $10.5 billion for the, if we really want to have a sustainable financing system, and it's 10.5 billion per year. So it's quite a lot of money, and so far the pandemic fund has not been able to get so much money. So clearly there are efforts made, but it's not enough. It's not sufficient, and it's not up to the need and the expectation, obviously. So how to convince donors and government? I think domestic funding, of course, is very important to support preparedness and One Health and PHC. So I think it's very important that government prioritize health over other spending. And here I think it's also a matter of advocacy to really show that health is not only a cost, but really it's an investment in prosperity. And as you said, health is wealth. So it's very important to convey this message, because still many people are just seeing health as a cost and as something that a waste of money. And the other thing, I think what is really essential is probably to use the COVID-19 experience to make a good investment case. Because many countries who had not invested before in primary healthcare or One Health have seen the devastating impact of COVID-19. And this impact has been not only on developed countries, but but also developing, and all countries have suffered from it. So I think there is here a sort of an investment case to make at local, regional, and global level to show that preparedness costs less than cure, and we better invest in systems that are contributing to a better response, like PHC and One Health, rather than waiting for the next pandemic to come. But again, I mean, I think mentalities are evolving, but we need to continue to push for more investment in health, in primary healthcare and One Health. Thank you.
Thank you. Thank you. Great answer, Dr. Xavier. Now we will go through the other questions. Our presenters, please take note. There are a couple of them. We still have 15 minutes left into our 90 minutes allocated. So we will use this time. Our presenters, please take notes so that you can answer our participants' question. There's one for Dr. Andrew specifically. How was the private healthcare provider engaged in testing, contact tracing, all of these community mitigation measures, contact tracing, testing, and treatment for COVID-19 pandemic? Someone, Fitura, said, thanks to all the presenters. To our last presenter, there was a mention of promotion of production of medical supplies. Can you please elaborate? I think they are referring to the last presenter, Dr. Masibo. For this one, can you please elaborate more on this, how to maneuver around such local production of supplies, but also locally improving, but delivered to be effective coping mechanism treatment, for example, streaming. Someone is asking, I think this is for the International Public Health Institute. Is there a certificate? I think maybe they're asking about after the program participation, whether there's a certificate. Effective, strong leadership and political commitment. This person said effective leadership and political are crucial for prioritizing and ensuring the implementation of resilient primary healthcare system. These include guiding policies, allocating resources, coordinating efforts among various stakeholders, adequate funding that we're just spoken about, and health workforce, capacity building, community engagement. These factors are the main factor we need to address. This factor. Okay, great. This person is giving additional insight. What was the challenges regarding COVID-19 vaccine acceptability in the community in Ethiopia? What was the challenges regarding COVID-19 vaccine acceptability in the community in Ethiopia? Okay, the same question. Please, can you say about the issue in order to address? All right, sorry. Yes, sustained financing essential for continuity. Okay, great, a statement. Thanks, Dr. Sylvia. Health is an essential investment. We need to say it loud. Feet on the street, money spent on war, conflict is not available for essential primary health care and HIV service delivery. Thank you for your great comments and engagement and participation. Can you go ahead, our moderators? Sorry, presenters.
Okay, this is Dr. Andrew Sayim. Can I start?
Yeah. Go ahead, sir.
Yes, so during the pandemic, the focus of control or the governance structure was lifted from the Ghana Health Service and the ministry to the presidency and then to the Ministry of Communication. So because it was lifted, the umbrella became so big that private sector, government sector, and every other sector were under that level. And the Ghana Health Service was the technical kind of director, but generally whoever the presidency or the Ministry of Communication wanted in, the job came in. And that's how everybody was able to be mobilized to come in. The Christian Health Organization, the Ahmadiyya Muslim movement, the private individual facilities, and all other organizations came in to join with various aspects, whether funding of the contact tracing or testing or the direct movements and all those other things. So generally, it was the focus of governance that was reorganized so that everybody can be in the umbrella. The other thing that we've seen over the period is that in our district health management information systems, we have been trying to work with the private sector to collect their data into the national database. And so over 1,400 private sector facilities are now in our district health information management system, and we are working with them so that now we are engaging them when we are doing capacity buildings, various meetings, we are working with them. So during the other epidemics, they were all involved because we are already forming very strong bonds with them. So that's how we used it. But during the COVID specifically, we had raised the control level into a non-health issue. So everybody got involved in all the private sector. Thank you. Over.
Thank you. Doug, do you have?
Can I continue?
Yes.
Yeah. Thank you. I'm really very much pleased that there is a great questions and some suggestions even. I'm really very grateful for interaction of our participants. I think to highlight few on one is on local production of medical countermeasures, medical supplies. I think it's a very important thing to really add self-sustained systems for outbreaks. I think that's one of the great lessons we had. There was big challenges we had, but like we cannot keep waiting for another pandemic to happen and work on it. So as earlier said with our panelists, we need to work in the peacetime. Even though COVID is there, even though we are not in the ideal peacetime, I think we are working on main things. One is on products. So we are trying to replace imports in countries. So currently we are importing almost all our supplies from outside. So we need to focus in country to substitute that importation. So import substitution is one thing we are doing. The other thing is we are trying to have advanced technology in country, including vaccine manufacturing. So we are importing, not only like the whole of Africa is importing vaccines. If we have this week, there is a great news from Rwanda. There are vaccine manufacturing started with support of some European countries. So it's very important to have that diversified in regional manufacturing capacity. So something, if Rwanda produce something, Ethiopia will consume. If Ethiopia produce, it will be distributed through Africa. It's like connected. We are working with African Free Trade Proclamation, which is get a momentum currently. So we are using those platforms to have one market for 1.2 billion African population. Also, we have African Medicine Agency, which is under establishment, which will give us a kind of regulatory clearance for us, because regulation is very important. The other thing is very important, as the question mentioned, the capacity of local knowledge, indigenous knowledge on the traditional medicine. It's very important. We have so many examples here and there, but we need to prove, we need to market it, we need to make it modernized, we need to make it assessed, we need to make those traditional medicines promoted in the great arena, of course, with the understanding of their quality, their effectiveness, efficiency. But traditional medicine is one of our priorities. We had a clinical trial team established under Arman Hansen Research Institute, one of the specialized institutes recently reformed to focus on the traditional medicines. And also in the ministry, we have a team focusing on traditional medicines and supporting traditional medicine wisdoms in country. So Africa was full of indigenous knowledge. We believe that indigenous knowledge can be transcribed to modern knowledge and the modern know-how. So that's important. I think I plea most of you participants to work on this area and the researchers on going forward to make proud the whole of Africa. That's one of the important things. And we have incentive package, be it tax, be it foreign currency access. There are so many tax and the government support is on local production and local manufacturing. I think we can discuss that. If you can email me anything, I can link you with the proper thing. So we have good policy for local production. The other very important thing is like the thinking is like any resilient system, primary health care systems could be built with WHO framework of health systems. I think we believe. So if you go to governance, financing, delivery of those supplies, and then so any perspective which should go with the health systems is very important. So Malcolm Alamai, one of he suggested that strong leadership, adequate funding, health workforce, community engagement are factors. I really believe, I really agree and concur with him. These are very important factors. Thank you for mentioning that. We are also had vaccine acceptability. I think it was not an issue that much from our assessment. For example, if you go with some of the regions, 98-99% coverage of the distributed delivered vaccine was delivered. Our problem was financing. Our problem was vaccine availability at the peak of the pandemic, because we had no vaccine for 8 months in country because of the hoarding we have witnessed elsewhere, because we are not manufacturing that. But there is some resistance in the urban area because of the social media, because of the misinformation, disinformation, but it's not that much big and a big problem for a country like Ethiopia because our success was big. We were challenged with deliveries, with last mile, with financing in the workforce. Other than that, I think we did pretty good to reach our people in the rural areas, especially. There was a problem somehow in the urban areas. We worked with religious organizations. We worked with social media influencers. We tried to use multi-channels of media to reach to the population. So I think it's something important, but I don't think it's a problem. For one last thing, on One Health, it's a very important thing to link, invest more in the primary healthcare in the One Health. I totally agree. Ethiopia is trying to invest through different fundings. We had some fundings from World Bank. We had some fundings from Global Fund. Also, we won pandemic fund, which Dr. Sylvia mentioned earlier. I think we granted with 50 million of $300 million pandemic fund advocated. This is almost 1/6 of the funding goes to Ethiopian proposal. I think we had that collaborative working spirit. We tried to witness and we showed the lesson for the world that One Health can be possible in countries who are developing. So this is one of the areas. And also we are working in the WHO arena on pandemic accord, on pandemic instrument, and also IHR revisions to include those lessons, those important things, including financing for dedicated for public health emergencies, for IHR capacities in the pandemic preparedness. So we are very, very on front to work and to materialize this and include that in national planning and in the also evaluation mechanisms. Thank you.
Thank you, Dr. Masivo. To piggyback on exactly what you just said, Dr. Sylvia, I want you to throw light on this one about manufacturing vaccines and distribution and supply chain of medical countermeasures. COVID-19, the pandemic, taught all of us about the inequalities regarding these issues. And all three presenters, you were very keen enough to tell us about the global interconnectedness of the world on how we approach these issues. So how do you think that the inequalities of, the rich, versus the poor, and who gets first? Because I know Africa was at the tail end of the distribution supply chain of COVID-19 vaccines. And yet we talk about global health security, interconnectedness. How do you juxtapose, and what would be some recommendations of how to approach this the next time? As we all keep saying, the next pandemic is when, or epidemic is when, not if. Thank you.
Yeah, thanks. I think it's a very important question, because this is exactly what member states are currently discussing when they are negotiating the treaty, and try to have agreement in place that ensure a little bit more equity for the next pandemic. Because the current global system for a medical product is based on a business model, which is that when you have a rare product, usually the prices are very high. And this is exactly the case when a pandemic starts, where even if there is a vaccine, usually the amount of vaccine available is very small. And so sometimes it's the first come is first serve, or the ones who have the capacity to buy a lot buy it all. And so obviously it leads to a lot of inequity, especially at the early phase of the pandemic. So what kind of system can we put in place to reduce this inequity? I think first it's very important to understand that it's useful to address this issue from a broad perspective. I mean from an end-to-end process, because those products for rare and emerging disease, usually in peacetime there is no market for those products. So, but when a pandemic strikes, then suddenly everybody wants them. So we need to first understand that it starts with the research, and then goes to the manufacturing, and then the procurement, the supply, and the delivery. But the research aspect is very important, because we need to push industry to do research on products that are easily available or usable everywhere else. Because, for instance, for COVID-19, one of the vaccine was requiring a cold chain at -80. And so not many countries have this kind of cold chain. So we need also to develop products that are usable almost everywhere and at the lowest cost possible. Otherwise, by nature, the product itself creates inequities. The second issue is really on terms of geographic distribution of the manufacturing capacity. I think that there is a lot of discussion around it, and there have been very interesting initiatives, such as, for example, the mRNA vaccine hub in South Africa, where there is an attempt to transfer the technologies of mRNA vaccine to many more countries, and making sure that this new technology can be developed elsewhere than in developed countries. So I think these are the kind of initiatives on tech transfer that are really interesting and should be supported. But one caveat, I think, on tech transfer is that first, it takes time. And tech transfer is not only just the transfer of technology. You have also to think the system around this manufacturing capacity. After the after the influenza pandemic, and before as well, there was a global program from WHO called GAP. And this GAP intention was to transfer technology to different countries so that they can produce influenza vaccine. So the technology that was used was an egg-based vaccine, so not a brand new technology, but still requiring tech transfer. And many countries have embarked into this GAP initiative, have developed the capacity for manufacturing, but some of them faced real challenges, because first, there was not enough domestic market for this production. So the company was producing it, had to make the difference with other products that were coming on were available internationally, and it ended up that the local production was more expensive than international products. So after some time, the country just dropped the national production because it was not sustainable. So we need also to understand better the environment for those production, to make sure that they are sustainable, and also that it really meet a need that is not only a need during pandemic situation, but really a long-term need, so that you can ensure that there is a need for this production on the long term and not just for crisis.
Thank you. Great insight. So yeah, this is where, organizations like the Coalition for Epidemic Preparedness Innovation, CEPI, using AI technology and mRNA technology to produce vaccine in about 100 days when a pandemic strike or before pandemic, to have products availability and mobilize resources to get those products to countries. Thank you for the insight. So we are, sadly running out of time. It has been an incredible session from our great presenters. Thank you very much. I know you asked some brilliant questions. We talk about sustainability at some of the way for sustainability and financing, especially domestic financing and funding, to deliver common goods for health for our populations around the world. We talk about the interconnectedness epidemic starts and ends in the community, and all of these, we should get prepared for them. With something that a lot of us did not talk about is about the issue of climate resilient healthcare system, community-based climate systems, risk communication and community engagement, integrated disease surveillance, epidemic control systems, global health security index, or global health security agenda, action plans for countries. Some of those things that were discussed. I see that participants are still asking about certificates. The organizers from the International Institute for Primary Health Care of Ethiopia and with the Johns Hopkins University, I think they will give you feedback regarding some of this. But our last, so let me join me to thank our presenter, Dr. Sylvia, Dr. Andrews, Dr. Masibo for the great presentations and the great insight that they have given us to the very fabulous. Now we'll turn the floor over to Dr. Closer, who is the principal investigator of this project, to make some closing remarks.
Thanks so much, Tolbert. And Sylvia, I see you had your hand raised, so please go ahead.
It was a mistake, sorry.
Oh, all right. Well, thank you so much to everyone, to my colleague, Tolbert, for generously offering to moderate the session, to our wonderful panelists, Dr. Mabratu, Dr. Andrews, and Dr. Sylvie. Thank you so much for your participation. Some great comments and takeaways about the importance of preparedness, thinking about preparedness, not in terms of something quick you can do, but in terms of building long-term strong PHC systems, encouraging robust streams of financing, supporting frontline health workers, building strong relationships with communities. These are all really critical. We will all share certificates with participants via email, and we can also share the presentations as you've been requesting. So you will get an email from the Institute with this information. So thank you all so much for your participation. We really appreciate it. And we look forward to seeing you at the next webinar. Thanks so much.
Thank you. Bye-bye, everyone.
Thank you. Thank you. Bye-bye.
Bye.
Thank you.